I was curious to ask you, what are like, if you had to name maybe the top three sleep complaints that you see women coming to you with, what would you say are like the real challenges that your patient population has been experiencing?
Yeah, I mean, insomnia is number one for sure. It's insomnia is the number one reason a person will schedule with me. Oftentimes, it's a second opinion. Um, Sleep apnea, I think that's pretty common too. I think there is more awareness about sleep apnea, which is fantastic. And I also think I'm seeing younger people and younger women. And going back to what you were saying about the hormones, yes, I mean, in the luteal phase, there's people have worsened sleep that once they start their period, it gets better. And then there's also PCOS is a big one that's a risk factor for sleep apnea. I think there's like a 30 times higher risk of having sleep apnea if you have PCOS. There was a teacher at Stanford named Ann Stella Robinson, and she would say, it's DIMS day, disorders of initiating and maintaining sleep. And I think it was an ICD-9 code. But, it's some version of insomnia, and then sometimes it's daytime sleepiness.
So I got to pick your brain about this because I want to know some of the tools that you have found really work. And for those of us listening, when we talk about Dr. Mayer being literally someone who has behavioral sleep medicine training, she really understands what the gold standard is, which is not to throw pills at you, but rather to do cognitive behavioral therapy. So I want to step outside the box of cognitive behavioral therapy and the tenets of that and see if there are any CBTI adjacent tricks, especially since one of the hardest things that I found to manage, regardless if it's men or women, though we're tailoring our conversation today to women, is the people that wake up at like 2, 3 o'clock and they can't get back to sleep. And it's really a struggle to figure out a solution for them. I'm going down the rabbit hole of, are they getting suddenly a cortisol spike? Is there something else going on? And I wanted to know what seems to work for your patients. What do you do for them?
My approach is to always really try to fully examine the entire sleep picture. So not just what's going on at night, but what's going on during the day as well. Normally there's more than one reason. There's a circadian component. There might be a sleep disordered breathing component. There could be an anxiety or stress component. There could be a hormonal component. And what I try to do is I try to stratify in my mind which one is the most, which one contributes the most. The only way to come about that is to really assess the person and talk to them a long time. And then, I tell my patients, we're going to be on a journey. I'm not going to be able to solve your problem today, and I might not be able to solve your problem in 3 visits, but I will work with you through it, and we'll get to the bottom of it. And we may need to cross a few things off of our list. We might do a very abbreviated form of CBTI where we're not doing a full CBTI protocol, but we're really looking at things that might help sleep hygiene, that might improve circadian entrainment. We might be just looking at stimulus control therapy. Those modalities from CBTI have their own research data that shows they're effective. Not the sleep hygiene, but the stimulus control or time in bed restriction. I use melatonin a lot. I use light therapy. I think it really comes down to, why is that person waking up? And almost always there's a behavioral component to it. Even if like the root cause is sleep apnea or stress, there's a behavioral or a condition component to it if it's been going on for a while.
Have there been any things that you've noticed, like any tricks in terms of people who are particularly very anxious or stressed when they wake up? Things that you've done either even before they go to sleep or when they wake up, or any other like tools in your toolbox that you think have been really effective?
Yeah, so the most common athlete that I'll work with because I live in Seattle is ultra runners, like people who run these like 200-mile races and they don't sleep. And what we talk about is having a sleep ritual. And if you look at any athlete, whether it's a basketball player or a swimmer, they all have rituals because there's performance anxiety, right? And performance anxiety happens with sleep as well. And if you have a person develop a sleep ritual that sort of anchors them into this expected routine, and most of the time it goes well, they can go back to that in the middle of the night, and it can help them, it can facilitate falling back to sleep. So that's one way, that's one strategy. Another strategy is something called imagery rehearsal therapy, where you tap into the person's visual system as a way to facilitate going back to sleep. Stimulus control is very important. I think people really, really underestimate how important that is. I see people all the time that they've done a really expensive digital CBTI program, but you really talk to them about the implementation and they're not implementing it correctly, because people just, it's hard to compute why I would get out of bed would help me fall back to sleep, because I know if I'm not in bed, I'm not sleeping, right? But a lot of it is around mindset shifts and teaching people to be more open and have a more beginner's mind, because people develop these ways of thinking, oh, it's impossible to sleep, my brain is broken, I'm wide awake, if I wake up past this time, I'll never fall back to sleep. So in order to facilitate the possibility that that will happen, you sort of have to break those beliefs. I always tell people, you could call it a growth mindset versus a fixed mindset. You could call it positive psychology. You could call it cognitive restructuring. These are just different names. You could call it mindfulness. These are just different names but the way you're thinking about it, you have to open yourself to how to solve it, and then you're open to approaching the problem in a different way.
It's almost like shifting your identity, really. That's how I like to think of it. It's like, how are you identifying? Are you identifying as that person who will never sleep? Or are you kind of open to saying, I want a different identity? Like, what's my ideal avatar, if you will?
Well, I mean, would you agree that there are some people with insomnia, and you could name any medical disorder. It could be someone who has seizures or is dizzy or has migraines. The same sort of phenomenon happens where people do identify with the diagnosis in a way, and those are some of the inspirational stories that we read about, are people who didn't let their leg amputation define that they were not an athlete, and
right.
It's so inspirational. And so that's what we're trying to do, is say, yeah, sure, that you do struggle with this. It is a big deal. It is really annoying, and it is stressful and serious for your health. However, let's figure out, where do we have, a way to do something about it? What can I do?